record button.
I think it's recording. I got a message to say,
It was earlier. I just switched it over to my
Yeah.
computer to download it.
okay.
So it's re-recording now. So hi, everybody. If you're watching this recording sometime in the future, I'm Mike, one of the PGY4s and chief residents here. We're blessed to have Dr. Chang, Mudfud, here to talk to us about psychiatry board prep for the ITE. Dr. Chang, the floor is yours. Thank you very much.
Awesome. Thanks, Mike. It's good seeing everyone all here. Like I was telling Oz and Mike, big kudos to you all for joining us tonight for like the board review. So what I wanted to do today was just to be, in the years past, what I've done is I tried to make this a little bit more concise, trying to make this around 30 to like 40 minutes or so, just really kind of high yield topics. And rather than talk about some of the more abstract ABEM topics from the educational experience, this talk is really aimed at the boards. So it's really kind of high yield information, content that's been kind of from a proportion standpoint, really showed up in high frequency from behavioral health standpoint in the boards, as well as just, I would say, high level general strategies with regards to the boards and the behavioral health questions. So definitely, if you have any questions from this talk, feel free to drop me an email. I'm happy to talk one-on-one and even separately beyond within the psychiatry and behavioral health things. Happy to talk about test strategies and just taking the boards and stuff. And it's an exciting time that you all are in, just insofar as that there's been a lot of changes both with the recertification and I'm sure that Oz is kind of in the inside scoop of just the discussions with regards to probably the testing strategies for like even certification kind of going on in the future. So this is an exciting time, but that's still, regardless of how the format of the exam is, it's still going to really try to test kind of the content that you have all been exposed to during your residency training and kind of how you can kind of frame that and assess that. So what I'll be talking about is really kind of anxiety disorders and medical clearance. Those are the two kind of big bread and butter areas I'm going to focus in on. And the reason why I'm going to be focusing on is that just if I was very curious as like a research person, kind of looking at from a proportion standpoint, where do these behavioral health questions kind of show up on the boards? And I was very fortunate to have some good colleagues and friends kind of within like ABEM general who have kind of like discussed with me and like shared with me some kind of not the specific questions, but more kind of general categories of questions. And we do see just from a broad picture that medical clearance, anxiety disorders, schizophrenia, those are really, depression are really kind of the high yield topics, I would say, that you expect to see within like psychiatry or behavioral health topics. So what I'll do is like, I'll talk about anxiety and I'll talk a bit about medical clearance too, as well, like guidelines and test strategies. So again, one of the key ways of constructing this for the exam is thinking about this idea of most common reasons for, quote, failing medical clearance. So it really ties together nicely with some of the other modules within the core curriculum with regards to toxic metabolic, neurologic, infectious. And so a lot of that really dovetails together for the psychiatry section. So when we think about the psychiatry section, what we want to start thinking about is really, is thinking about how do you take that kind of like the haze of behavioral science and assess it? Because I mean, a lot of the behavioral and psychiatric questions are really, by definition, pretty subjective, and there's a lot of heterogeneity, a lot of mix from there. And so, what ABEM General has really kind of tackled it from the testing standpoint is really started focusing on DSM criteria. So the DSM criteria is essentially the diagnostic standardized. It's the kind of like the quote Bible for classification, at least within the United States, for psychiatric conditions. And so this is where, like, unfortunately, I think a lot of adult learning is a lot of construct, concept-based. There are a few times where you just have to do rote memorization. And I think this is unfortunately one of those times where I would say the DSM criteria is kind of low-hanging fruit for getting some quick hits for boards. And of course, there's so many different disease states from the DSM, the previous DSM-4, from the Axis 1, Axis 2, to doing away with those axis categories with the DSM-5 and just the specific disease states. But I would say these are kind of like the big ones: major depressive disorder, bipolar affective schizophrenia, obsessive compulsive disorder, panic disorder, and post-traumatic stress disorder, PTSD, as being the really high yield ones that if you wanted to get some quick points or quick hits, this is where you kind of really focus in on memorization from those standpoints, because I think knowing some of those criteria that you'll see in past exams, they'll be like, well, this is an individual who's been having lots of anxiety since their breakup, and they've been having these symptoms for about 3 months now, and they're coming to you and they're saying, and one of the choice stems is what is this person presenting with, and one of the possible answers is PTSD, and you kind of have to think about, well, what's the criteria? Is it 30 days, 3 months? And I think that's kind of in the lines of the memorization aspect for that. For PTSD, you're really looking at for 30 days and below. So 30 days and below is acute stress disorder, 30 days and above is PTSD. So that's like not any like genius kind of revelation. It's really just a rote memorization from the criteria there. And so if you spend some time looking at it from there, that'll be some nice good hits, quick hits for you when you're doing your exams. For the personality disorder, Sam, what we used to call the access to, the two big disorders that have really come up in previous exams have been borderline personality disorder, BPD, and antisocial personality disorder, ASPD. And we'll go into a little length in a few minutes on a specific slide about that from there. But taking aside from the rote memorization aspect of the behavioral science questions, I think that ABEM General really likes conceptualizing using the psychiatry questions as really a platform to introduce other questions, other topics from other domains. And so what I mean by that is there's lots of questions that really revolve around managing agitation, for example. And I think that oftentimes you'll see some of the question stems being around this patient comes into area D and they're feeling very hyper, and the nurse and the other staff members are asking you to kind of give them sedation, and what's the first clinical step you do? And I think there's a tendency to say, okay, we'll just give them sedation and be done with it. But what these question stems often are trying to ask you, are trying to probe, is really, have you thought about a differential for agitation? Have you thought about what are some of the other reasons why someone is feeling kind of fired up or showing some psychiatric complaints? Because there's a whole litany of other things, from physiologic, infectious, toxic-metabolic, neurologic, that can be driving this agitation. So ABEM General loves talking about agitation as a secondary way of getting to some of these other topics in like the core curriculum. And that also leads into like delirium too, because delirium is also a really kind of nice topic in a sense of identifying reversible causes versus something that's really more kind of at its like steady state baseline, so like dementia. And so kind of the questions between time course is also another thing that the boards really likes to explore. And so that's kind of like what I would say, like a 10,000-foot view of how we conceptualize these behavioral health questions in the realm of your boards. But now kind of getting into like a little more like the nuances of it. So with schizophrenia and depression, those are really kind of two of the biggest topics within psychiatry, just because of both the prevalence as well as the frequency of complaints that we see here in the emergency department. We oftentimes aren't the first people to diagnose this, of course, but we are oftentimes individuals who have to manage individuals with established diagnoses of depression or schizophrenia. And one of our big jobs is really trying to understand the differential for that. And so besides the DSM criteria, which I'm not going to put over here, so I'm not going to kind of like kind of bore you with like 10 font like slides of the DSM criteria. You guys can, it's easy accessible. You can kind of Google that. That's all there for you kind of look at. But one of the things that ABEM has been really interested in, ASAP in general, has been this idea of the pathophysiology of possible pathophysiology of depression and schizophrenia. And there's been a lot of currency, what I would say, over the last 5 years with regards to the dopaminergic hypothesis for schizophrenia. And what that is basically is at its core is that there's this hypothesis that there seems to be an overabundance of dopamine that's associated with some of the psychotic symptoms that we see in patients with schizophrenia. Now, where exactly the dopamine is, kind of what zone in the dorsal lateral prefrontal cortex, I don't think you need to worry about that. But there has been a few kind of questions in the stems in the past with regards to dysregulation of neurotransmitters, and dopamine in particular for schizophrenia is like the one that we as emergency physicians really be aware of. On the flip side, the serotonergic hypothesis for depression is also quite well established. It's a bit controversial within the psychiatry literature, just because I think a lot of more recent literature has kind of showed this idea that it might be more of a dysregulation of like glutamate and serotonin in tandem. But I think that the nuances of that is secondary to really what I would say what you see in not just ABEM, but ABEM, like the American Board of Internal Medicine. And these are some of the 7 questions, is really looking at this idea of that there seems to be lower serotonin associated with depression. And so at its really kind of core, you can think of it as just a dysregulation of neurotransmitters. For dopamine, it's a little bit too much. For schizophrenia, for depression, is a little bit too little. And I know I'm kind of reducing it to like a very simplistic model for this, but these are commonly held theories that we have seen in board questions before in the past. And it's something, if they are going to go into pathophysiology, something that you should be aware of. And it also dovetails with the mechanisms of the treatments, because oftentimes you might see questions related to how does olanzapine work, or how does Haldol work, things like that, or paroxetine, or like sertraline, or paroxetine, like Prozac, for example. And so knowing the mechanisms of these medications is also something that's quite important. So with antidepressants, selective serotonin reuptake inhibitors, SSRIs, those medications really just tinker around with your serotonin system. And so probably remembering from like med school days, preclinical days, it tries to kind of increase your natural uptake of serotonin. And so it's also one of the reasons why this incident, this is not going to really be on the boards, but just more just out of clinical interest. There has been historically this idea of an increased suicidal ideation in individuals who recently start SSRIs. And the theory behind that physiologically is that it takes a few weeks for the serotonin receptors to kind of upregulate. And during that time, you have a little bit of a gap between the upregulation of serotonin and the actual steady state of the individual. And it's that time that serotonin kind of is a little bit out of whack that you unfortunately see sometimes with certain patients, an acceleration of some of the suicidal ideation, or even kind of a disinhibition of suicidal gestures, because serotonin from a behavioral standpoint has also been associated with disinhibition. So something that just kind of like something that I haven't seen this before, tested before in the past, but it kind of ties together this idea of the relationship between serotonin, the antidepressants, and ultimately this hypothesis on what is associated or what's driving depression. The monoamine oxidase inhibitors, remember from like USMLE, like the tyramine cheese effects and things like that. That hasn't been tested recently, just because they're so rare now in there. But just kind of like food, just kind of putting it on your foot for a thoroughness kind of like standpoint too, as well as its interface with like tyramine too, and just kind of be aware of with individuals who are on MAOIs. But again, they're so infrequently prescribed now that I think I'd be pretty surprised if you started seeing that. I mean, that's been kind of phased out, kind of like in the written boards in the last few years. Antipsychotics still are really kind of fair game, and I'm really thinking about it from the Haldol class and atypicals, and in particular, Haldol is. I just recently did my research. Oz, I don't know if you've done your research recently too, but now you can do them like online. It's actually incredible. You used to have to do another exam, the concert exam, but now you can actually just take a couple of take-home exams. It's actually wonderful. It's a lot more less stress than previously. But when I did my recertifications, I was surprised, but they were still testing on a lot of questions with regards to classic antipsychotics and dopaminergic effects of that with Haldol. And so the classic effect you see from that is because Haldol, the way I think about it is like Haldol kind of blunts your dopamine, so it decreases your dopamine, and then you start beginning to see almost Parkinson-like effects from that. And so Parkinson-like effects has some extrapyramidal like motor movement issues. And so that's one thing from there. But then even from another thing is like your tardive dyskinesia. So the tardive, like you're dancing, you're having all these movements, and that's associated with some dysregulation of both dopamine in addition to some other neurotransmitters. But if you do see a classic stem is an individual who is coming in feeling very agitated, is brought into the psychiatric psychiatric section of the emergency department, and they're very, very kind of upset. And what do you think is the cause? What would be your next step in terms of the management for this patient? And I think it's trying to lead you to that this is not just an individual who's emotionally upset, but maybe manifesting some secondary extrapyramidal symptoms from tardive dyskinesia. And the management for that is, anyone remember the management from that is? Thoughts? There's a great medicine that we use a lot for lots of things.
Benadryl?
Benadryl, yeah, exactly. Like, yeah, Benadryl. It's like Benadryl. Benadryl is wonderful, and it kind of calms down the receptors, and it's pretty amazing, kind of like how the time of onset from that, in terms of helping to sustain some of those symptoms too as well. So I know we use Benadryl now more likely in the setting of some of our folks who take, say, Reglan or Phenergan. You start getting I feel super jittery, but just also remember that it has tie-ins to some of the antipsychotics. And then the last thing here is like, it reminds me of that movie like Ocean's 11, where like in the scene, like Brad Pitt's like, and there's one thing you cannot do, and it's like, and then the scene cuts out. It's like no the. So sorry, that's just like an error from my part. So there's no other in addition, no the. But just going back again, so depression, schizophrenia, remember, it's really high yield. It's going to be a big proportion of this question stems. And so if there's something you really want to memorize, depression and schizophrenia are like two of the biggest ones. Now, anxiety.
Hey, Bernard,
Yeah.
can I ask you a question?
Yeah, sure.
Do you know, the standard sedative that we use with our mental health and, well, our emotionally disturbed patients, to use that acronym, it was Haldol, or is Haldol and Ativan. But I remember the day when we used to add Benadryl to that, the old B52.
Yeah.
Do you know why we've moved away from that?
I think that it's been more talking to like a lot of the toxicologists, like toxicology friends, is that I think that they think that particularly among the psychiatry crew, there seems to be almost this potentially iatrogenic kind of effect of, you have the combination, you sometimes get a little bit of going overboard with the Benadryl effect from there. And so that you get a little bit too much of the sedative in addition to in concert with the Haldol and the Ativan. So I think that people have kind of like stripped that one away among the three kind of choices from B52. They stripped that one away because they felt that that one was a less precise, and also the one that potentially had more harm in terms of other toxic side effects, other things that kind of lead to it. I mean,
yeah, and I don't know about your experience, but I'm not sure. I mean, it'd be nice if we had one of our tox people here, but I wonder whether the effect of the Ativan kind of blunts the extrapyramidal side effects of the phenothiazine drugs, and therefore like you said, it's just downside, no upside to using the Benadryl.
Yeah, no, it's a great point. Yeah, I think as like, at least anecdotally, that's been like my kind of like experience too as well. But it has been interesting too, because I think even like from when I was like as a resident, that was very, very common, like in Boston. And I think now, even in the beginning, when we first started here in New York, I think it's like it's over the last like years, over a number of years, it's kind of really been stripped away.
Mm-hmm.
And I think at least talking to Ryan Lawrence, from like psychiatry, I think that even within CPEP, I think that's been a tendency away just because of this potential iatrogenic, synergy from there.
Mm.
But another pearl from this is like separate from like ABEM, just with regards to Haldol, is that, of course, the big fear we worry about with Haldol is like the long QT. You might get some type of really bad cardiac side effect from there. Just the reassuring standpoint is, if you look at most of the it's granted most of this is retrospective data, but as long as you're giving Haldol, hopefully IM, the long QT cardiac prolongation, really symptomatic cardiac things, you do see they're really quite rare. and they're much more often seen in an IV administration in individuals who really are kind of like held-on naive. I think that the standard practice of the 5 and 2 like IM approach, there really has been some good safety data with regards to like the QT at least. I mean, not speaking about some of the other sedative effects or whatnot, but at least from that standpoint. So I still kind of as a general practice, I like getting an EKG if at all possible for individuals before giving them 5 and 2. But I also realize from a practical standpoint in area D, sometimes it's just not feasible, or it's just, it's just, trying to think about the implementation of some of these things versus the reality of how we are operating in like the clinical environment that we're working in. So, but it was just more as a meant to reassure you, even if you don't get the EKG, at least the data seems to support that it's quite safe from the long QT. With anxiety and suicide, these are two other really big things that ABEM General really likes, in particular from suicide. I think I would say as a general rule of thumb, the big factor for disposition is safety. And what I mean by that is that you'll oftentimes have question stems related to, is this person safe for discharge? Is this person safe? Can we ignore what they're saying, et cetera? In general, I would say from an ABEM general standpoint, you usually should reassess any individual endorsing suicidal ideation, particularly if they're intoxicated. If they say endorse suicidal ideation when they're intoxicated, in a reassessment, they say, hey, I'm totally fine. I have no idea what I was saying. It's in general, from that standpoint, that reassessment, if they have a good safety plan, you are okay sending them home. Now, that's not to say that, again, there's a maybe sometimes a divorce of what we do in clinical practice for what the exam, but I'm just talking about thinking about it from the exam. There really has to be a big emphasis on safety assessment and reassessment for these individuals. A discussion with psychiatry, practically speaking, at least within Columbia, I imagine too at Cornell, individuals who are with active suicidal ideation, we are engaging our psychiatry colleagues and doing, our classic physical exam, search, et cetera. But I think from the standpoint within ABEM General, it's really thinking about these individuals from the standpoint of closing the loop for safety, and not just with a disposition, but making sure they have adequate follow-up and communication. Because I think that one of the big challenges is you have to remember that these exams are written for all emergency physicians, not just folks like us who are important area at academic medical centers, but practically speaking, many emergency departments do not have psychiatry facilities, 24-hour for psychiatry. And so we really have to kind of think about from that standpoint, how do you manage some of these patients? And so this idea of closing the loop, having a safe discharge, and having kind of a next point of care contact is something that's fair game. That's recently some literature that was published in the Annals of Emergency Medicine with regards to management of patients with suicidal ideation. And they haven't quite turned this into an actual policy statement, but there have been a number of peer-reviewed papers kind of in our specialty now talking about that individuals with suicidal ideation, with a safety plan that do not seem to be an imminent risk, you can consider in consultation with other specialties about whether or not they need to be admitted or discharged. And I think the questions probably won't exactly ask you to do that, like should you admit or discharge this patient, but they will definitely kind of discuss questions of kind of involvement with family members or loved ones, and kind of like a collaborative kind of communication standpoint from there. Any questions about that? I see there's a chat. I'm sorry, I'm going to pull this chat to see if there's any.
It's nothing professional, Bernard. Don't look at it.
Oh, okay. All right. So kind of then moving on from suicide to like anxiety. So again, with anxiety, aside from memorizing some of the DSM, one of the things that anxiety is useful is a great medical differential. And so it's oftentimes going to be something that people are going to be asking you about. This 25-year-old individual is feeling palpitations, feeling short of breath, and they're feeling super, super anxious, and they're sweaty, and everything's trying to push you to say, oh, it's just a panic disorder, but maybe it might be some hyperthyroid issue, or maybe it might be some medication ingestion. And so All these things are just strategies, not just for the written boards, but also for the oral boards. I think, I mean, Oz is a super seasoned oral examiner, and it just is the idea that you want to think through your differential, almost talk through it. And I just as we were thinking about in real practice, I always say I have like my differential that I think is most likely the case. But before I get there, I need to like walk myself through cognitively through what other things it could be before I kind of get there. It doesn't mean you have to take a million other tests to kind of get there or like work someone up the wazoo for that, but you want to at least be aware of it. And so with anxiety disorders, just think of anxiety disorders for the purposes of for our boards as a nice kind of chief complaint for us to really work through a big differential, a big medical differential from there. PTSD is interesting insofar as they sometimes talk about the difference between acute stress disorder and PTSD. The difference from that's really time course, 30 days and before for acute stress disorder, 30 days and above for post-traumatic stress disorder, PTSD. There has been some talk now about some of the work that we've been doing here at Columbia, just the idea of PTSD and the following, not just sexual assault or war trauma, but also individuals with medical illnesses. So you might see some question stems with individuals with lots of anxiety after a stroke or a heart attack. And that actually, it might be a cue that they've had an extensive negative, if the question stem says they've had extensive negative medical workup, their MRI is negative, neuro seemed off and signed off that one of the question roots, I mean, the question possibilities could be to refer them for like behavioral health, like kind of like support or whatnot, but something to be aware of with regards to PTSD showing up in the emergency department setting. And then obsessive compulsive disorder and phobias are really more kind of potpourri of just trivia, just thinking about social phobia, agora, fear of certain things, arachnophobia, fear of certain things that that's really not so much in the domain of within emergency medicine, but it has kind of popped up surprisingly in past with that. So there's something to be aware of with regards to that. So again, I think that these DSM criteria, low hanging, but time consuming fruit. So low hanging, just if you had, you're going to be so busy kind of really focusing in on a lot of cardiovascular trauma, respiratory conditions for the boards. And if you want to focus in on psychiatry, schizophrenia, depression, anxiety, and suicidal ideation, those are the really big ones from there. This, I just wanted to show just kind of as a little bit of like kind of a bonus from this standpoint is that I was just kind of working with the American Psychiatry Association, kind of like they've been thinking about kind of their kind of like CME training programs for non-psychiatrists. And they've been really trying to hammer home this at this point within PTSD is that it's like a three-part component. So this is something that I don't know ABEM General will be kind of exploring, but eventually they're trying to get this framework for all non-psychiatrists to think about PTSD as a triangle of a stressor, something that causes you some stress. It's not just a stressor, but it also intrudes in your daily life. And then the last thing, it causes you to avoid certain things, like avoid like the stimuli. And so in particular for individuals who've survived like stroke or heart attacks, the biggest challenge is that you're trying to avoid the stimuli, but the stimuli is yourself. And so there's this enormous kind of pressure from these individuals for their recovery and their long-term like well-being. This over here again is kind of this idea of functional impairment resulting from the above. So you really want to think about with psychiatry conditions for ABEM generals, how do these diagnoses ultimately impact your functional well-being? And I think that that is something, if you're thinking about from an admission standpoint, this is more from a practical kind of clinical standpoint. This person might have low levels of depression or anxiety, but if their functional impairment is so severe, that might warrant getting our psychiatry colleagues involved or getting some like timely follow-up for these individuals, even though you might not feel from an acute medical standpoint, this person might warrant like an admission. They should definitely get plugged in before being discharged. I think that also there has been in the past autonomic lability, this idea of PTSD causing your fight or flight symptoms to kind of really go haywire. So you're really kind of just wired. I mean, that's why kind of you see a stereotype of someone with PTSD is always like hearing like super like jittery. And that's something also like in the stem of some of these questions of an individual who's very, very sensitive to the emergency department noises or sounds and things like that. So all these things are kind of like leading into like whispering you to think about this notion of PTSD for these patients. Panic disorder, again, is similar to PTSD with kind of like your autonomic arousal, but is really more about this unexpected arrival of when it comes about. So it's something that kind of seems to kind of come on sometimes without provocation, sometimes with provocation. But it's the differentiate you might see, practically speaking, from a test question is there may not be to be a specific case index event like a trauma or something like that. And so sometimes these question stems look similar, but just, if you can't identify the specific stem of like the event, the traumatic event, then probably lead more towards panic disorder. Red herrings for the psychiatry world within the emergency department, definitely be cued into like arrhythmias. So someone with panic disorder who's saying that they're feeling like their heart's like beating like crazy. Maybe they're in SVT, or maybe they're having runs of VTAC. I mean, there's other things too that you want to be aware of. Of course, PE, she rears her head everywhere. So PE for lots of individuals for why they're feeling short of breath or feeling kind of gasping. And so I think that oftentimes the nice thing with these in the written boards is the stems will often often give you like the vital signs and et cetera. So really focusing on that before you start diving into psychiatry, always kind of think about some of the rest of the, your vital signs or basics before I kind of dive into that. And then I think this is like psychiatry is a realm of like the potpourri of questions. So endocrine and ingestions are a big, toxicology shows up a lot with regards to this, as well as like endocrine too. So in particular, like, the stuff like for med school, Cushing's or Addison's, or thyroid or hypothyroid or hyperthyroid. And these are one of those times that you could consider then giving like beta blockers or other, even like discussing these ideas of like how do you treat like hyperthyroidism or hyperthyroid, like a thyroxic storm. Some of these questions are kind of the nice tails into the endocrine world, just using psychiatry as like the foundation or like the background story. Any questions before I start diving into medical clearance? Let me look into the chat too.
Hey, Bernard.
Hey,
Just some this is awesome. This is so great. Just some comments just for the residents. The PTSD, unless they've changed the criteria, I agree with all of those things. Another just common feature is just the hypervigilance that the person has. Just maybe that goes with the intrusion, but just the practice. And then if not mentioned, I did join a little bit late, but I would very much have you all be facile with serotonin syndrome, neuromuscular malignant syndrome. I think neuroleptic malignant syndrome. I think those are important to know. So if they're, for NMS, if you're on like one of those old school, like the stem gives you Haldol, Mellaril, Stelazine, some of these old school medicines, and then they're giving you all of those like rigidity and hyperpyrexia and some of these other things, mental status changes, then you got to think about the antidotes that are there. So you got to be thinking about dantrolene, bromocriptine. And then with the serotonin syndrome, just make sure if they have like, you mentioned the MAOI, but if there's multiple serotonin-like medicines together, then you do have to think about that. And you guys know the antidote there, cyproheptadine. So just those are some of the things to be thinking about in this realm.
Awesome, that's great, Manish. Thanks so much. And I think that this really is psychiatry is like as I was saying, kind of early on in this talk, is really the platform for ABEM General to kind of think about the potpourri of the diversity of some of our scope of our practice as emergency physicians that doesn't quite fit into, say, the cardiovascular bucket or the renal bucket. And toxicology is definitely one of those big domains too within that psychiatry is a great launching point for discussion of that. And also just kind of thinking about more like the meta science questions of like, how do we approach a sick patient, or how do we kind of like tackle some of these patients that we see in the emergency department. And so medical clearance is also something that is kind of discussed at times, and with regards to, in particular, with regards to individuals with psychiatric complaints. I'm speaking about this. I was Manish, I was talking to Oz recently. I was like redoing my research, and there's now a lot of interest with regards to medical clearance and like the component ingredients required for a medical clearance for some of our behavioral health patients. And so some of the questions I've had for myself, like, are there guidelines by ASAP, and how do we apply them? And then how does this figure in the exam on our written boards? So for medical clearance, there have been a couple of guidelines kind of put out, both by ASAP in years ago, 1999, 2010. Recently, there was another one put out about like 5 years ago that kind of talked into this as well. And really just trying to think about the short-term, I would say, risk posed for our patients with regards to acute medical conditions outside of the scope of their initial chief behavioral complaint. And so one of the things here with med clearance is thinking about it with EMTALA, so with transfer, so like kind of the two worlds colliding. And so reading this over here, so within reasonable medical certainty, there is no contributory medical cause for a patient's presenting psychiatric complaint. So at that point, the patient can be deemed stable to transfer. So this is a lot of verbiage in for that, but what it's really trying to distill is this idea of that we've done as the treating provider our due diligence in terms of doing a primary assessment and an evaluation for this individual's chief psychiatric complaint. And we can say with our professional judgment that this individual's primary psychiatric chief complaint cannot be attributable to something within a medical reversible complaint there. So it's really doesn't mean that you have to take a gazillion tests or imaging before you rule someone out, but it does mean really kind of taking a good history and physical, really kind of doing kind of some chart work to really explore, to Manish's point, their medications lists, and doing kind of a lot of detective work for these individuals before we can kind of say, okay, I think in my professional judgment, this individual who's coming with suicidal ideation their primary complaint is suicidal ideation. Doesn't seem to be anything else that seems to be driving that chief complaint. And so what medical clearance does not imply, though, because I think we're just going down into like the weeds of it, is you can have ongoing medical issues that need attention, like hypertension or diabetes, and be medically cleared. It doesn't mean that if you're medically cleared that you're completely zero medical complaints, your comorbidities are healed and you're totally fine. You can have active medical issues. It's just that they're not the primary driver of your specific chief complaint, or they're the primary, I would say, like driver of this patient's care in a hospital setting. Like I would say, like someone who has suicidal ideation but is also in DKA has a very different story, because I think a lot of managing this individual's DKA is is very, very active. It's taking kind of primary importance in parallel to their psychiatric complaint. So you can have an active medical, having, say, a UTI is not a preclusion to not being medically cleared from there. And you can also have illicit substances or some toxic metabolic process from that standpoint, but and still be medically cleared. Again, it goes back to this full circle, this idea of with medical clearance, you're focusing in on the primary complaint and also the primary, I would say, bandwidth of the provider care that's being occurred in this specific visit. And so if that individual is coming in for a psychotic episode, and they also happen to have diabetes and their sugars are a little bit high, but they have their standing medications and they're not in DKA, you've done your due diligence, they're not in DKA or HONC or anything like that, that individual can be medically cleared and with kind of like continuing their longstanding diabetes regimen while their primary issue of psychosis is being managed on the psychiatric floor. But I think some of these questions surround the questions that I've kind of like encountered before in the past have surrounded this idea of an individual with the primary behavioral complaint, but also has some other medical complaint that is not active in a sense that like dominating this person's specific complaint. And the question is, is this person like appropriate to be, triaged or to be evaluated or ultimately kind of cared for by psychiatrists? And I think from this, you can kind of see that there is a rationale for allowing that. Now, the ACEP consensus summary, the most recent consensus summary, kind of with regards to serum tox. So serum tox are not managed for medically stable patients. Now that practice pattern might be different at Columbia or Cornell. Like I've had many personal experiences in Area D where I'll say this, and at the end of the day, I just get it. So just to kind of move things along. But you will probably, if there is something with regards to tox screens, see something like this, that you don't need them for medically stable and patients. And going even a step further, routine blood work is neither mandated or necessary for medical clearance for psychiatric patients, but maybe the big caveat is but may be indicated in a proper clinical context. So again, it's like a lot of words to say. You can use your clinical judgment if you think this individual needs to have this kind of work done or not, but it's not necessarily mandated or part of like quote the standard of care. And you can kind of rest assured from that standpoint that our college is kind of like backing us up from that standpoint. Now, Corfel was saying like the reality is like oftentimes it's not just consultants that may want that out of practice patterns, but practically speaking too, facilities where some of our psychiatric patients are admitted may have as a policy require that. So I think that, I say this with some empathy for our psychiatry colleagues that like, even though I think that I agree completely with ACEP's clinical policy from that standpoint, but I think the reality oftentimes is that from placement standpoints or disposition, they may need a drug screen or some basic blood work. And so, I don't push back as much with our colleagues just because I understand where they're coming from there. And hopefully there'll be eventually some interdepartmental policies that kind of lead for that. But, Manish and I have talked about this before in years past, and I think it's just kind of hopefully trying to get all the the stakeholders from psychiatry and emergency medicine and medicine all on board. And, it's like a work in progress as always. Now, what to do like in Area D, like kind of in the psychiatric area here in Area D, kind of putting in from there with medical clearances. So this is not really kind of on the boards area, but this is like what I put down for my like kind of like my epic kind of like expandable just with regards to medical clearance. I mean, there is one that pops up pre-populated, but I oftentimes kind of put this in there, and I like to put this in there particularly with the outpatient medications, just because oftentimes for our psychiatry colleagues, they may not be as comfortable as you guys are with managing hypertension or AFib, et cetera. And so having some of like this is the time that we're almost kind of putting on our outpatient hats to kind of at least put some of that there now to kind of lead the smooth transition of care for some of our patients with our psychiatry colleagues. Now, coming back to the main ED, so thinking about ways that like you bounce back, so individuals who kind of bounce back from medical clearance. This was kind of an interesting study that kind of looked at retrospectively at what were the reasons why we went back to the main emergency department. And oftentimes you see it's from vital sign instability, so like your blood pressure went low or it's too high, finger sticks, and lastly, altered mental status. So again, this is something that with question stems is that if you have a question stem about a person who's quote medically cleared and then brought back, that should be a red flag that, okay, this is probably not a psychiatry complaint and something that's driving it. But from a real world example, just thinking about it for us when we're working clinically is just reflecting when we do have some quote bounce backs coming from CPAP back into Area D or the equivalent at Cornell, it's just thinking about the top three things that we usually that we see, at least from a data standpoint, is usually these three here, and kind of running through your own kind of personal kind of like cognitive map of how to kind of think about your differential for what's driving them back and how you can address that or kind of explore it from there. There's also kind of thinking about it when something was medically cleared, but also ultimately had badness, like had a bad outcome. And this is also into some data that we kind of did within New York City. Most frequently, we saw toxic metabolic, so hyperglycemia, hypertensive urgency. Cocaine chest pain was actually quite common. Alcohol withdrawal was really common too, and then methadone overdose, individuals who just kind of remain somnolent too as well. So all this ties again into from thinking about it from a board standpoint of using the behavioral chief complaints as a point of entry for a whole range of other physiologic complaints that we treat as emergency physicians. So as a summary with medical clearance, there's no real consensus guidelines, but there really is this idea of communication with the psychiatric team, understanding their views and perspectives, and documenting really, and also explaining your rationale for why you want to do something or why you don't need to do something. And I think that really goes towards kind of like what I would say like decision-making aspects of emergency medicine, and something that's really fair game within the exam itself. So that was pretty much it that I had this evening, just with regards to some of like the general psychiatry, some of the main Axis 1 conditions that you oftentimes see, in addition to the medical clearance aspects from there. But I think that in the future, I've given this talk of medical clearance to the residency in years past before. We kind of dive a little bit deeper into some of the data and the details of kind of like streamlining clearance, and how do you kind of like get alignment with the different operational things. I would love to talk to you, in the future about that. But for the purposes of the exam, just really think about, again, as the behavioral health module as this kind of really nice area where they can explore different domains of medicine, kind of using the behavioral health as like the stem to kind of start it off from there. So thank you so much, guys. I know it's really late, and I appreciate you guys, hanging in there kind of for the education.
We appreciate you.
No, absolutely.
Have a great night, everybody.
Cool. I think Dave is up now, right, Oz?
David, are you there?
Yeah, I'm here. I was gonna say, if that's late, then what am I? Much later.
I missed you, man.
Yeah, same.
Yeah.
It was,
Yeah, I've been following all your successes from afar. Really proud of you.
yeah. Well, yeah, I'm not the one with millions of dollars of grants, so you're the one that's taken over. But I don't know, if people want to take a quick break, and then I'll hopefully make it interactive, and then I'll run through this super exciting topic of eyes and ears and face and all that stuff. Just a couple minutes.
I think that's a good plan. Let's plan to restart at 9:30. Do you want to do 10 minutes or?
It's up to you. I can start anytime. I don't know what people need. I can, go in a couple minutes. I can go at 9:30, whatever you want to do.
Let's plan for.
Yeah.
Hey,
I think people did think that it was over the way that it kind of it closed. Like I almost logged off too. I think a few people left, so maybe we could text them.
yeah, also, can you hear me? I'm in a bad reception zone, but I just wanted to say, I couldn't speak up when Bernard was there, but for the senior residents, especially when you finish and leave, I guess all residents, I don't like to use the term medically clear. I think that's a term that is suggesting that I then take all future responsibility for this patient within the short term, which I don't think is appropriate. So when I assess a patient, I make a distinction if the patient's medically low risk. And I make that point. I only chart it that way. I tell the person I'm handing off to. So just as a semantic thing, I don't say clear. I'm not really sure what, I don't think that's an appropriate term personally. I know what people
Manish,
mean, but that's what I
agree with you. I use the word medically stable. Now, stability can come and go, but at the time that I'm seeing them, they're medically stable for rather than using the word clearance.
Yeah, I like low risk. That's my
That's a
my,
good
my
one.
term.
Maybe
Yeah.
I'll adopt that one too.
Yeah, all of that is good. The thing that I commonly put is patient is currently medically stable for psychiatric evaluation. That's usually what I write in the chart.
I think psych always knows they can come back to us if something changes. Nobody's immune from decompensating. So
Yeah, agreed.
yeah, but I too do not like the word clearance.
Well, it was actually a cardiologist that told me, like, he's like, the anesthesiologists and the surgeons and everybody wants me to medically clear a patient. They're like,
Yep.
I can't, I don't know what's going to happen during their procedures. A person may have a bad outcome due to the medicines they give or the procedure that the intervention they do. So like right now, medically or cardiologically, they're low risk, and I was like, I'm going to adopt that. That's great.
Yeah. What's even worse is not our medical colleagues, is when our law enforcement colleagues ask for like fit for confinement. So like essentially like saying that they're good for the entire their time while they're imprisoned.
I reached back out to the resident group, said to folks that were restarting at 9:30. So hopefully some more people will log back in. But Dr. Bodnar, if you need, I'm your man. I'll make this so interactive. You're going to be nauseated.
All right. Me and you are going to go back and forth. That's what it's going to be.
Hell yeah. All right. We got it. I'm going to go make another drink. I'll be right back.
All right. Anybody that's still on, can you see my screen? Does it show a slide? Is that
Yeah, Dave, I can see it. It shows the ENT Optho board review.
okay? Good.
How you been?
Good. How are you?
Good, man.
Michigan looking good.
I know, bro.
FSU got
What's that? I
screwed.
know.
FSU got screwed, and that screws you a little bit too. But yeah,
No, because here's what I thought. Like, first of all, I thought they certainly deserved to be there, but they should have been the third seed. So they should have been playing Washington. And then we should have been playing Texas.
oh,
as
well,
the
that would
four.
be not great either. But I mean, I understand why they did it, but
I understand why they did it. It's just funny because whenever people are like, oh, it's about the bag, and I was like, if it was really about the bag, then actually, I'm sorry, SEC, you want the biggest game? That's Michigan, Ohio State. That's 20 million or 30 million eyes. You want that? So it's not totally about the bag.
well, I mean, well, there's some of the. I mean, it's just, but it's also knowing that, like I mean, they just like know that the competition, like it's. Yeah, but it's also, I mean, if they would have done that though, I mean, well, then maybe if it was really about all the bag, then what they would have done is it would have been Ohio State, Michigan, Georgia,
and Alabama. Yeah, it would have been those four.
That's what they would have really done if that was like fully going on all that stuff.
Right, I agree. I'll just say this: like, I think it was a bad system with 5 power conferences, 4 positions. What they really, I wish they would have done is just made it either 6 or 8 teams this year and said, you know what, we've got like 6 or 8 teams that are deserving, and then just ran it that way, right?
I agree. I mean, my opinion is to get rid of the conference championships and then just expand the playoffs so that
Well, now it'll be 12, and they don't have to deal with this, but you take away from some of these games, it's just going to be jockeying for position now. And maybe like first round buys and that kind of stuff. So, but I mean, you're going to eliminate all the drama of if you lose this singular game, you're out kind of thing, right? So
yeah, and I mean, I have to say, I mean, this is just nostalgia, and I think of getting away of
Getting in the way
things-
of corporate profit.
well, that, yeah, I mean, well, college football and like amateurism, like I think all that stuff is gone. Obviously, this is minor league football essentially, but but
Yeah, or semi-pro, right? Yeah, semi-pro, right, exactly.
yeah, but it's they've gotten, but I miss the old system and all that stuff, but that's it's kind of
Dude,
the
I know.
yeah,
No, I know. But you look back at all those like old school Nebraska, Oklahoma games. I mean, God, like that was something special, you know? And
yeah.
anyway, I'm with you. I'm with you. So we'll see. I'm actually like, just like the hats or the sweatshirts say, man, give me anybody. Like you put Georgia there, you put Alabama. Like I don't want anybody to think that they didn't deserve to win it. Now we may lose, but I like my team's chances. I think we got as much chance as anybody to win this whole thing. So we'll see.
Yeah, I mean, I would say Michigan's probably, I would say, is probably the favorite. I just feel bad for those kids from, Florida State. They didn't do anything.
Oh, yeah.
They didn't do anything wrong other than have their star player get hurt.
They got
No, they
Yeah.
got screwed. They did everything right.
Yeah.
Everything right. Those guys, that was. But the thing I keep thinking in my head, they don't ever, you hear all these analysts like, oh, we're sorry and we're sympathetic. Nobody cares about your, like, they don't care about your like sympathy for them. Like they just want in, like I'm not talking about you and me. I'm talking about like the national pundits and all that stuff. They're like, oh, we feel bad. Like they don't care about how you feel. They should have been in.
They want it the best to get, but I get it. But it is like, I mean, we'll see what happens, but I bet Florida State sues the NCAA and we'll see what happens.
Oh, well, DeSantis already said he will. But and if Florida State wins against Georgia, they're going to claim a partial championship.
Well, I have to say Georgia's got a gripe too, but I mean, yeah, that's why you need to expand all this stuff. That's all the problems with it. But
yeah, agreed.
Should we start? I don't know if we should go or.
Yeah, I think we can do it.
Okay. All right. Yeah. Sounds good. I would.
That's nice. All that was recorded. That's great.
Oh, that's good. Yeah, they can all hear that, the debate. That's good. That's good.
Pause the recording. My bad.
That's good.
Channel.
But I would hope people, talk, I don't know everything. I want to have a discussion about all this stuff. I'm just going to go over a lot of the material, that I've compiled of things that, that I've noticed on exams and a lot of it, not just the exams, but are, I think, pertinent to practice and know that's just kind of practical knowledge for us. So I'll go and we're going to talk about, ENT and Optho. So here we go. So you guys probably don't need this as much as me, but I haven't done this before, but I thought I would just kind of level set with anatomy slide to at least for the eye. Because I don't think we go over that a lot in terms of the anatomy. And so just the basics of it, of what we're actually talking about. And this can make us feel better when we reach out to their, our eye colleagues so that we don't sound like idiots when we're trying to describe the area. But, essentially, the cornea is the whole area that we see that overlies the pupil and everything that we can see, with the iris. And then the white part of the eye is the sclera. And then I think most people know the eyelids and stuff that's outside of that. But then when you go inside of it, right, they connect a little bit, but there's the chambers, right? So then we have the anterior chamber, where there's continuous aqueous humor that's produced, and we'll find out why that's important later. And I think most people know too. And that's within that the pupils constricting and dilating, and that's where the lens lived. And then in the main body of the whole eye, the big chunk of it is the vitreous humor, and that's providing pressure that pushes around our retina and the smaller part of the macula and the optic nerve. And if you lose some of that pressure, then you can see how that can be detrimental to the eye itself. And then the control of how the lens is dilated and how we can see far or near, and how that's disrupted is controlled by this ciliary body. And so some of those things just to keep in mind. And then it's always helpful, because reviewing an exam is to talk about some cases. And so people tell me what they think, but I'll read quickly. 77-year-old man with diabetes, has a 4-day history of progressive worsening left ear pain, hearing loss, discharge. He's febrile, he's fatigued, and his canal looks bad. It's got stuff coming out, and his glucose level is 400. So what do we think about this? What's true about his condition?
Pretty bad.
It's not good.
So this is probably, I think, first question is figuring out what it is. Probably necrotizing otitis, right? I think is what the question says.
Malignant otitis externa.
Yeah.
Son for correcting me.
They're both the same thing, but yeah, necrotizing or malignant otitis externa. But what makes it that?
The foul drainage, high pretest probability given his diabetes history.
Yeah, that's good. And he's got systemic symptoms, right? So, all of those things. Like, we see stuff that, people have just run of the mill otitis externa, and that's, we call swimmer's ear. And people that have seen this, like, people don't look sick, like their ear hurts, but they don't look ill, right? They definitely don't have systemic symptoms. It's usually the classic thing. Either they've been, it's called swimmer's ear because it's, people, that typically are getting things, a lot of like either bacteria or water or the things in their ear. But I have to say, in my experience, at least in New York City, I find it mostly where people are scraping their ear or putting up, like being aggressive with Q-tips or other things in their ear. And then they develop like just like a soft tissue infection in their ear. But classically, it's, the externa, just like run of the mill otitis externa is, Pseudomonas staph is what you're thinking of. Fluoroquinolones is what you want to treat it with. And then, there's not evidence for this, but I personally do it where you give them in combination with the antibiotics, some topical steroids to help just with the inflammation. And anecdotally, for me, it seems to work. What do you guys think about what you do for the malignant or the necrotizing otitis externa?
I mean, if staph is a concern, I would assume that you're going to be wanting to give something to cover both staph and Pseudomonas. So probably broad spectrum antibiotics. Vancomycin would be my assumption.
Yeah, so you're going to be more broad with the antibiotics. You're going to be, giving IV antibiotics. We're obviously going to be calling our ENT colleagues that usually aren't super excited about it. But the concern is that it spread further, and in the worst case scenario that they have to go in intervene. And then if you're that concerned about it, you usually want to do some more advanced imaging to evaluate the extent of it. And we know that, like this case, people that are more prone to any infections, the elderly, immunocompromised, and diabetics, are going to be the ones that are usually the culprits of this. All right, how about this? Which of the following is true?
Hey, Dave.
Yeah.
Hey, Dave. Sorry to jump in, but also for the group, if you are worried about, and I agree, malignant's a bad word because it's not cancer, but it's really a necrotizing infection. But if you are worried about that malignant otitis externa, also consider antifungal treatment, because you can get mucor in the nose, or you can get mucor there in the ear, essentially. So one of the medicines that you would do topically at the spot for the tract could be something like a Volsop, which is like an acetic acid vinegar, essentially. But you may want to talk to the inpatient team about some antifungal treatment as well.
Oh, that's interesting. That's a good point. Some of the treatment that they talk about, honestly, it just at baseline with a something that's not even a malignant externa is talking about just using acetic acid if you want to just try like vinegar to see if that helps with the ear. So that's a good point. Yeah, to an adjunct. So that makes sense. All right, which of the following is true regarding the treatment of otitis media? This is kind of like an epi question, but this stuff comes up on exams, and I mean it's pertinent to our practice. Although we're often guided, based on the population that we're treating and how savvy they are and expectations and etc. But what do people think?
I know the way I approach these questions is what I think is less likely. I don't think A is likely. I don't think B is likely. I don't know about E, so I'd cross that off. So I would say I'm probably between C and D. And my gut feeling would probably go to D.
Yeah, that's right. It's D. This is like, people have expectations. Oftentimes, anybody that works telemedicine, they'll know that one of the most common reasons is people getting on because they want a prescription. That's what they expect. And so this is the most common reason for people to get antibiotics. And then despite that we know that, 3/4 of these cases will get better without treatment. And so the idea is to try to consider not doing that. And then so having some recommendations about where you go with that. People that will go on to treat kids, this is a big issue that you can think about. But essentially, the big cutoff where they come up is 2 years old, or is where the bifurcation is. If you're 2 years or older, like you can consider observation period in the appropriate patient. And then younger than that, then there's some other considerations. And so if they're really young, less than 6 months, they get antibiotics. In that intermediate period, you usually give antibiotics, and I would err on that case, definitely as an emergency provider. But there are some cases where you might consider that. But the older, the 24 months, the 2-year-olds, you can try to avoid it unless they have some other more concerning features. They have a high fever, it's both sides, or they've got like significant otorrhea, then you can give it. And then the good thing is that they can often get a shorter course of antibiotics. And then the treatment covers the bugs that I've described. I think people know, which is strep pneumo, H flu, and then the catarrhalis. And then amoxicillin is usually the choice. And then if they've had it before, then you can consider it a broadening out to augment. So not real big guns. All right, 42-year-old man, left ear pain, posterior auricular pain for 3 days. You see the ear. What's the next step? And what are we dealing with?
I wonder if it's mastoiditis. It's like, I don't know, the story could be a number of different things, like maybe trauma, but I don't see like a battle sign. I'm not sure what this picture is trying to tell us. But it doesn't, the outside of the pinna, I guess, does not look super inflamed and angry like a perichondritis. So if I would guess, I'd say mastoiditis, and they probably want a CT.
Yeah, it's a call. That's what it is. It's helpful. I mean, when I've seen this is, obviously if you can look straight at the patient, you can see one ear is like this and the other one's not. And so one of them, is jutting out. And so the idea is to look up, but that's a great call and great reasoning. So yeah, what you're looking for is the, inflammation behind that ear, and then the ear kind of, Mickey Mouse, juts out, and then it's usually pushed up. And then the hallmark features what you described is that you know, the redness there, you know, there's like some irritation behind there, and then there should be tenderness along that mastoid. And so the typical bugs is, I don't know if they're still asking this, but they used to ask this stuff where, you know, be strep pneumo, you know, other strep, staph is a common one. And then the treatment is like the malignant case of the otitis is giving IV antibiotics, diagnose it with the CT, and then you talk to ENT. You know, there were previously, it seems like oftentimes they would try to drain a lot of this stuff, but it seems like or resect a lot of that. And the most recently, when I just checked into it, it seems like that's less effective, and so they're being less aggressive, and it seems like most of this can be handled with just antibiotics itself. Here's just a picture, just going through picture diagnosis. What are we looking at here?
Perforated TM.
Yeah, perfect. So what are you going to do with it?
Expectant management. And I don't remember off the top of my head. I'd have to look it up at work, but maybe antibiotic drops. I don't remember.
Yeah, so good. So people, it's, you know, there's a hole in the membrane. So people often complain of like a, you know, weird sensation in their ear. I've heard people talk about this whistling sound, or just if their hearing's off. I heard them say hearing loss. They said it's just kind of off. I've seen, you know, plus or minus, just like you said, that people say to give topical antibiotics. I don't think that that's definitely clear, but the one thing though is more preventative care is like trying to avoid things that you can put in the ear to make it get infected. So you know, no swimming, basically not, you know, submerging your head, that you're going to get a lot of crappy things that can get in the middle ear. And then, but what are you telling them to do once you find it in the ED? Like, what are you trying to tell them to do?
I mean, pretty much that. I tell them not to use Q-tips. Like 2 of my TM perforations that I've had clinically have both been related to Q-tips. And I usually tell them not to use Q-tips, make sure they're not putting anything in their ear. And I actually agree with the middle ear infection stuff. I tell them no submersion water, make sure they're not getting water in their ear when they're showering. All that sort of stuff.
Yeah. And then they usually heal on their own, just like you said, but they need ENT follow-up. If it's big enough, then they may need to, you know, like have a procedure, but it's rare. Yeah, exactly that. All right. 34-year-old man, altered mental status. He was assaulted. You look at his ear. This is what you see. What are we looking at?
Good old hemotympanum.
All right. So what are we worried about?
In addition to I would say a basilar skull fracture. So
Okay.
I probably say posterior fossa skull fracture D would be my guess.
Okay. Anybody else?
No, I didn't realize I was not on mute. Like, if you guys heard me chewing, I was gonna say middle, the middle instead of posterior.
Yeah, that's the one that's they can be. There are posterior the fossa, but the one that we typically think about, especially, you know, around the ear, is the middle fossa, because that comprises the sphenoid and the temporal bones, which we're looking at. And we used to, CT scans have gotten better, but we used to really emphasize this because these are not well visualized on CT scan. And so the idea is, if you found some of these things, that you'd really want to be sensitive to that. And then what could you tell, like, how could you protocol the CT to tell them, or tell radiology?
Like thin slices through temporal thing.
Exactly. Because what's the problem with these kind of fractures? I mean, obviously, if they're sick for other reasons, you'll find other things, but
Hmm.
what are they prone to?
Oh, infection.
They are prone to infections, but why?
Because all the oral flora getting into the base of skull that way through the middle ear. I don't know.
Well, yeah, that's a good thought, but the base of the skull fractures, they're prone to having a dural tear.
CSF leak.
Yeah, so the CSF leak. And so the idea is that you want to recognize that and stay on top of that. Interestingly enough, we think that the vast majority of these things, like the the leaks in the dura, repair itself. But you want to keep an eye on it. And so if the leak persists greater than a week, which to me that makes me a little uncomfortable, but that's what the recommendation says. I mean, in our eyes, we're talking to neurosurgery and they're managing this obviously. But that's what the recommendation is. And then that if it persists beyond that, then they're being treated with antibiotics and maybe a surgical intervention. Just for fun, you guys know, like, let's someone has this and they're having like leakage from their nose and stuff. Do you know how to tell whether that's if it's CSF or something else?
The halo sign.
That's right. Yeah. So if there's like clear fluid mixed with blood, it has to be, if it's bloody for the halo sign, then you'll see like that, that the outer ring and then the middle ring of the blood. We actually have a test for it now. Does anybody know what the test is for the CSF though?
We're actually all talking about it in the chat. I'm guessing it's the beta 2 transferrin.
That is it. I can't see the chat, but that's what everybody's talking about. Yeah, that's
yeah. Matt Villani was just talking about it, and I said I've never actually sent that. Have you sent it before?
I sent it once. I think it took a while. I mean, it took a while to come back. I don't think it was like a day, but it was longer than everything else. I got kicked in the head with a soccer ball in med school really hard, and it like blew out. It like hit me right over the ear,
Jesus,
like, perfectly, and it like blew out my eardrum, and I was like bleeding from my ear. So I went to the ER at my med school, and I got like a CT head, and they called neuro because I was having like headaches, like I vomited, and I mean it was just a concussion, but they sent that for beta 2 transferrin, and it was negative.
Oh,
because I had like clear fluid leaking out of my ear, probably from all the inflammation. But
wow, that's crazy. Well, that imprinted in the concussion. Luckily, wasn't that bad, so you remembered the the whole thing. That's good.
I feel pretty impaired.
No,
going around my day.
Well, interesting. So, on top of that, do people know what the other signs, like the clinical signs for the basilar skull fracture? So, one was that hemotympanum, obviously.
Battle sign.
Yeah, battle sign, which is posterior auricular ecchymosis. And then raccoon eyes, which is tarsal plate sparing ecchymosis around the eyes.
There you go. And then, yeah, that's the battle sign. Unfortunately, these are usually pretty late, so sometimes people come to us later, but, usually we don't see these right away. All right, let's talk about some epistaxis. These are what my kids are doing nowadays. So, the nose is very vascular. Unfortunately, it's there's a confluence of many of the arteries that come together in the nose, and it's called Kessel plexus. And so when it's dry or it's getting like, we're in nosebleed season essentially, where it gets really dry and other stuff, then people irritated, and then it becomes friable, and then there's a lot of bleeding. And so that's the most common reason. And so we know that 90% of these are from the front of the nose, or what we call anterior. But there is, also like a 10% of these that come from the posterior portion, and that unfortunately is where the sphenopalatine artery gets involved. So let's talk about treatment. So what would you guys do? First of all, for what you think is anterior, what's your approach to the treatment?
So generally for those folks, I know we tell them not to blow their nose, but I have them blow their nose when I first go in there just to clear out any clots or debris.
I do too. That's a good call. Yeah, me too.
And then after that, I do obviously visual inspection and just to see if I can see any brisk posterior bleeding, which is the thing we're all concerned about. If not, then I usually advise that I come in already with the Afrin. I'll Afrin each nair, regardless of which nair is bleeding.
I love it.
And I'll advise them to do direct pressure, or more often than not, I'll go in with 2 tongue depressors and just squeeze their nose together with that. And I don't know, I find, which I think most of us would agree with, most folks don't actually do good direct correct pressure for this. So if that doesn't resolve it after about like 5-10 minutes, on my reassessment, I'll go in with TXA soap gauze, jam that up the affected nair, again, do the direct pressure. And then if that doesn't work, if I can identify a bleeding site in the anterior nair, then I'll consider doing silver nitrate plus or minus ENT at that point. That's generally my rule of thumb. Oh, and I can't forget this, of course, I'm sorry. The nasal packing, which if,
yeah, I mean, I love it though. You described that amazingly. Yeah, I have to say, I almost always get it from like clearing, like someone getting to clear it out and then actually teaching them how to do real pressure to the nose, along with the Afrin. I almost always get it to stop with that, because usually people are holding the bone, or they're not holding it well. And so I'm glad you described that. That's exactly. And then you move on to these other things, whether you need to do cautery or you need to use like medical therapy along with, which is what Surgicel has on it, or using the TXA on some sort of gauze. And then I would hope people, like, these compressive devices work. They work. But I would implore people to try the other things first, to be like very diligent about that, because the compressive devices are very uncomfortable. And then it usually involves them having to have a repeat visit to the ED. You have to use them sometimes, for sure. But be diligent about trying the other things. What about the posterior? You talked about the posterior. What are you going to do about that?
I feel like I'm probably gonna go to packing first.
yeah, I would say it depends
Just
on,
because, like, yeah, I mean, I don't really have much faith in my ability to look up there and see something and to zap it. So I'd probably just do like bilateral packing at that point and then call somebody.
and also I would think if they're hemodynamically stable. I mean, obviously the thing we get concerned about is brisk posterior bleed. I would say if I'm concerned for a posterior non-arterial bleed from the back of the nose, I'd probably go direct to posterior packing. I'm not sure if Afrin's effective for back there, but I guess it doesn't hurt to have them sniff it.
No, you could try it, but let's say, okay, we have these long tubes and it doesn't work, and you're like near where I'm from and you're in like middle Nebraska. Like, what are you going to do?
You're describing my job next year and it's scaring me.
Are you gonna, Mike, do you have an idea? Maybe you should put your Foley in there and then yank on it.
Oh yeah, I like that. Yeah, let's Foley it. Hell yeah.
Yeah, I like it. So that's, yeah. So obviously if you got all the resources in the world, like you put, you do what you got to do, you call your colleagues, and then you got those like posterior stuff. But one of the thoughts is you can use some sort of other thing that has a balloon device. You put it past it, you blow up the balloon, and then you pull it back to pressure. And so then that compresses that area. And then you can feel, this isn't done, this image, you have to then, oftentimes fill up this compartment, but then hopefully then you've stopped all of the, it's confined to this area. But, once you've done that, you're not done. Then, you have to, hold it into, oh God. Then you have to hold it into place. And then I usually ask them, but people need to, our teaching is that people need to stay because of that. The people are prone to having bradyarrhythmias, and they need antibiotics. And why do they have bradyarrhythmias?
Vagal nerve stimulation.
Yeah, that's right. Okay, let's talk about facial trauma. It's
Straight
really,
up.
Hey, Dave, they also have about a 10 millimeter mercury decrease of the partial pressure of oxygen too. So sometimes they may need to be on airway watch depending on if you're worried about dislodgement. But they, just be mindful that it can even change some of our oxygen, carbon dioxide type issues.
Interesting.
I wasn't aware of that, but that makes sense too as well.
And Dr. Bodnar, I thought you were going to show us a thoracotomy-like technique for securing a phenolphthalein bleed with this next picture.
Oh God, man. Yeah. It's if you guys, you're really in a jam, then you just like dissect the face, and that's how you get to it. Yeah, this is no, it's terrifying. Okay, facial trauma. Okay, what are we dealing with here?
That's a nasal fracture right there.
Yeah. Okay. So what are we going to tell them to do? And what are we looking for? Like the major, the anything that we're concerned about.
So we get concerned about septal hematoma for septal necrosis reasons.
Perfect.
My understanding, though, of septal hematoma from what I've been reading, though, is that it's not really an acute thing. Like folks will come in like 48 hours later. So for him, as long as he's aerating well out of both nares, I mean, even if he's not a little bit, probably just follow up with ENT and can consider reducing the nose in the ED, like if you were at a community shop or something like that.
Yeah, and I've seen it, honestly. I've done it at LMH where, like, I've actually talked to plastics, and I've moved the nose myself too, honestly, in place where people that have asked me to do it, I've done it myself to relocate it. There's no harm in that. And then the idea is to avoid the nose blowing. And I agree with you that the septal hematoma, that literature around that and this teaching around it may be a little bit vague, although it's still some of our teaching, and they think that maybe some of that might be secondary to like abscesses, and it wasn't really the hematoma, and that's what causes that, the saddle deformity. But that's at least, I think, what might be out there in some of the testing to put it out there. But you're very right. But yeah, all of that stuff is 100% right, but most of it is cosmetic with the nasal bone fracture, so not a lot to do with that. All right. Acute ear pain after trauma. What are we looking at?
Blood.
That is blood. It's blood around the ear. What's wrong with the ear itself, though?
Well, if the ear is actually like partially amputated, for lack of a better word.
No, the ear's intact. It's on a person.
Oh, auricular swelling.
Oh, like a hematoma?
Yeah, perfect. It's an auricular hematoma. So what's it from? What are you going to do with it?
I think it's you can get it from trauma, and I think if you're like 48 hours out, you can drain them. Is it like, I think you can drain them, but I don't know how far out you have to wait.
Do you have to wait any time?
I would no.
I think because risk is having loss of cartilage there, and then loss of the ear. So I would say drain, and then suture in some compressive bandages to prevent cauliflower ear, and rapid outpatient follow-up with ENT.
Yeah, that's great. Yeah, that's perfect. And so it's from it's usually from a rubbing, like a shearing force of the ear. Like you think about like rubbing it on the carpet or something. And so you shear the perichondrium, and we know that vascular supply is a little bit tenuous. And so Yeah, the idea is to do it earlier rather than later, and then the teachers, it's got to be drained within at least a week, but earlier the better. And then the the other things that I've seen about it is if it's small, like if we think it's a really small one, not as big as this, less than 2 centimeters, you can probably just use a needle to drain it and kind of watch it. But otherwise you've got to do an incision and really open it up and then compress it just exactly like you described. So, making a little incision, suction out the area. And then there's many different ways to do this, but something, either you're casting it around there or you're suturing something in place to hold it, because the worrisome thing is about it reaccumulating. And then these patients should get antibiotics to prevent infection. And then the other thing is, and I've seen this I saw someone have to come back, unfortunately, 4 times for this to reaccumulate multiple times, is to be watched. So they either have good outpatient ENT follow-up or somewhere that they can go so that it can be monitored so that it doesn't to come back again. And need to be drained again. Sometimes need to be drained again. And it prevents this, which I think now that the MMA has become more popular, everybody's seen this complication. But once it's a cauliflower ear, you're done. It's, it's essentially calcified, and that's your ear. I think some people wear it as like a badge of honor, but that's like a permanent deformity, and it inhibits your ability to hear. All right, so this is someone with facial trauma and a little bit of eye pain. What are we looking at?
Subconjunctival hemorrhage at the very least.
For sure. There's some conjunctival hemorrhage. There's some ecchymosis around the eye.
I would say what Matt failed to pick up on is that the left
Oh yeah, whatever. The entrapment. Some people just are cross-eyed. You shouldn't assume.
Being an astute clinician, I'd be concerned for little entrapment, Matthew.
What if he has like some weird like cranial nerve palsy on the left side?
Yeah,
that's true.
Because he's looking suspiciously directly at the camera.
That's true. The person could have a lazy eye on the left, and the right eye is just looking right at for you. It's possible. But in most people, yeah, this is displaying that there's an orbital floor blowout, and so there's entrapment of the inferior rectus muscle, and so that's like trying to look up. You can see the left eye is trying to look up, but the right eye is unable to do that. And so what are you gonna do about it?
Lateral canthotomy.
I hope not.
I'm just kidding.
Mm-hmm.
Just stick your finger up the nose and push the eye muscles back in.
Might be able to get there.
We gotta call someone.
Yeah, do you need to call them right now?
I guess not, the way you're asking it.
I don't know. Do you or not? Do you need to come see them right now? Like, do they need to go to the OR immediately, or can they see them a week from now? Or
I mean, I would say based off of this patient's presentation, I would want them to get seen now.
I would wake them up.
Yeah, I mean that's essentially like what we usually do, honestly, is to have them to see them right away. But the standard of care is, if you're somewhere where you don't have all of this stuff, like we don't work in the our quaternary care centers, is that it's urgent. It's definitely urgent, so they need to be seen within the same day. But this isn't somebody that you need to like wake up and like you got to see this person like right now. So it's it's just to arrange like follow up within 24 hours for them to see somebody, plastic, optho, whatever, to be able to deal with this. And then you're telling them like the other standard stuff, like giving them nasal decongestants. You don't want them like nose blowing and, you know, other things. And then it's controversial, but most people give them antibiotics too as well.
Question about that, about not the antibiotics, but how quickly they need to be seen. If I was at a like LMH, for example, or the Allen, would I have to transfer them if since they're supposed to be seen within 24 hours?
Great question. And so, you know, the Optho team is really great there. So like, let's say I saw this patient at 11 o'clock, you know, and then I call the Optho person and say, hey, I've got this, you know, their inferior rectus is entrapped, you know, they're otherwise fine. And they're like, that's great. You know what? I'm going to see them in the office, you know, tomorrow morning. Like, we'll give them that slot. That's totally fine. If they're like, I'm going to see them, you know, a week from now, you'd be like, no, man, you know, we got to figure this out. You know, you have to see them. But if that's usually what the fun thing about a lot of community places is they usually, a lot of them, like the good functioning places, have setups like that with common things like, you know, what we see like ortho, you know, derm stuff, and optho is like they have the ability, like, you know, derm is usually almost never anything, but these other things that are more acute that you can get them in. And I've at LMH, like acute things to try to get them in, I have almost always never had a problem with getting them in urgently for stuff.
Okay, great to know. Thank you.
Okay. This guy also had some trauma. He's not feeling great. Got a proptotic eye. He's got decreased vision. What are you worried about? He doesn't look like it, but he's got a significant amount of trauma.
Orbital compartment syndrome. We want a lateral canthotomy this guy ASAP.
Absolutely. Okay. Yeah. So he's got a retroalveolar hematoma. So obviously after trauma and all that stuff that you'd be concerned about all that stuff, and they're like talking about decreased vision and all that stuff. But what if this guy was unconscious and you saw this eye? How would you evaluate whether you wanted to decompress that eye?
Well, it depends how quickly you can get a CT. Or you
Does it?
can do a pressure.
Exactly. That's great. Yeah.
Or ultrasound.
I actually don't know if that's true, if you can ultrasound that.
Yeah. I did it for my ultrasound case of the month at conference a few months ago.
Yeah, so you know better than me. You can ultrasound to find whether there's like a hematoma, or you can.
Yeah, you can. It's called like a teardrop or guitar pick sign, but like the normal like circular contour of the globe like flattens, so it looks like a V at the back because there's pressure pushing from behind.
Oh, interesting.
Yeah,
I'll have to look into that. I mean, that makes
I think
sense.
it's like a pretty newly described thing.
No, that makes perfect sense. Yeah, that would be super helpful. Yeah. The current teaching, or at least that I know from the old guard, is that you have to do, you know, the pressure, just like you said.
Yeah.
So if there's any concern, the pressure is elevated, then you would decompress the eye. And I mean, we feel a little bit leery about doing these lateral canthotomies because it's weird to cut around someone's eye, but it can be vision saving. And when you talk to Optho, it's like these aren't. Has anybody seen Optho do these?
I've done two.
Yeah, so I've done about, I don't know, 5 to 10 of these. I mean, they scar down actually pretty nicely. You just have to clamp that, like you just clamp the lateral side there to devitalize it, and then you cut down, and then you take your suture scissors and you kind of like cut. It's not as elegant as you think, and then once you get down to the tarsal plate, you just got to snip the attachment there. It's not going to be like this satisfying, you know, blood coming out or anything. It just decompresses inside. And the
Yeah,
patients are often able to tell you, "Oh, I feel like a release," or like that's what they've been like. Oh, and the pressure goes down.
Yeah, I haven't done that many. I've only done 3, but I would say like the one that I've seen that we've done were a lot more delicate. And when I've seen ophthalmology do it, they're pretty aggressive. In the way that they cut. And I guess it's just like most of this stuff is pretty cosmetic. And that's what I was getting at, is like my takeaway is that the fact that they think of it as less of a big deal. And if we think this is going to save, like a disability, that we should be less scared about, doing it and just, perform the procedure if we really think it's going to affect the patient.
Yeah, so I was actually going to say I've actually done a few lateral canthotomies that have already technically been canthotomied by outside hospitals that transfer in. And Opthos always says like the referring hospitals are never aggressive enough in how they're cutting, because the 2 that I was able to assist with, both of them never actually had their lateral canthus tendon cut, because they just didn't go to cut. So just like girls from Optho.
I mean, I get it. I think that it feels weird to be cutting around the eye. And so I think we're, a little bit concerned about that, but yeah. But yeah, I've seen them be very aggressive. All right. Somebody wasn't nice when they were out in the middle of the night. This happened. They got hit in the face. What do we got?
The jaw split in half.
Yeah, they have a mandibular fracture. So what are the things like you're asking for? I mean, you're looking at it here. Like, what are we seeing here? That it's
I mean, it's like, I don't know. I mean, clearly like the mandible is just split right down the middle. But I guess like I don't know. I think like malocclusion, I guess.
yeah, it's a big one. Yeah. So if
so
it's
like,
less apparent than that,
yeah.
when you ask them like if their teeth don't come together the same way, that's a big red flag.
Yeah. There's a tongue depressor test that I heard of.
Yes, it's actually been studied, and it's
pretty good, right?
It's very good for that. Like if they can't do that, if you ask them to bite down and you can't break it, then they definitely need imaging.
Yeah. Do you guys know what that is? Rachel, Amy, everyone else? Okay, well,
No.
Okay,
No, I don't.
So basically you like take a tongue depressor and you like lay it flat, like, and you tell them to bite down on it, and then you twist it. And people who don't have jaw fractures are able to keep their teeth clenched, and you can break it as you twist it. Yeah, Mike just linked to it. But people who have like jaw fractures or malocclusion, they'll like release, or they won't be able to hold on to it before you break it.
Yeah, exactly right. So essentially, if you can do that, you can say, I don't need imaging. If they, if you can, if they stop, then you need imaging. It may not mean that they have a fracture, but it's pretty likely that they do. I mean, some things aren't as clear as this. If you see like a, gum line laceration, like you see this in uneven teeth, I mean, what you're dealing with, obviously, but most of them won't have stuff like that. So exactly things that you're looking for like that. But a big question to ask is the patient is to ask them if they feel like their teeth come together. And then I'm glad you brought up that tongue blade one, because that's the big one. And so what's the best imaging for this is a good test question. What imaging are you going to get?
CT max face.
Yeah, that's what we're going to get. But what's the best imaging?
Is there even a more specific, like CT mandible?
That's so funny. That's
MRI
so
with and without contrast.
No, it's not an
No,
MRI.
no, it's actually an X-ray.
Yeah, it's a Panorex, which
It's a
is
Panorex. Yeah.
which is funny, but that is the gold standard for this, which is, and it still comes
Yeah.
up sometimes, but
Guys,
I just put that out there because I mean, obviously we're going to get a max face, but that sometimes comes up as it's the best imaging. Is a Panorex, what you do in the dental office where they put that thing, on your face and they like wrap it around. That's the best imaging for it.
Hey, Dave, a couple of points on this. So, there are occasions where a person might have an alveolar ridge fracture, but you would not see a step off like you're seeing here and the level of malocclusion. This is a symphyseal fracture. Also remember that the mandible is a ring. So typically there's a second fracture. So you'll see one piece of it here, and often the other one might be somewhere out by the condyle or something like that, or at another spot. But usually it's two parts that break in the ring.
Yeah, agreed. Manish always has the high level points. I like it. So what are you going to do with this?
I mean, this patient I feel like needs OR. Would be the exception. So ENT, facial trauma.
Yeah, they need all that stuff. What else?
Oh, I was saying in the chat, I forgot you can't see. So I would treat this as an open fracture. So antibiotics.
It's perfect. Yeah, they need operative management, antibiotics, tetanus. Tetanus is the one thing to not forget. All right, and then they're just like moving on to some things that often come up in the test is like mid-face fractures, the way that they classify it. And people know about the Lefort system. It's just like it's in increasing of what we think of higher velocity fractures. And so there's a Lefort 1 through 2, through 3, sorry. And then it's basically like it goes from like the upper jaw to like the mid face to essentially like the whole face. And then you basically can tell, and I don't recommend that you be aggressive about this, but like a floating palate versus like you can see like the rim of the the alveolar rim, and then the whole thing is like the whole face is moving. All of these obviously require oral surgeons or ENT, whoever's handling these, but the Fort classification often comes up. But does anybody know the history behind the classification?
Didn't somebody hit like a bunch of dead bodies, or am I misremembering things?
No, that's exactly right. There's like the old French surgeon. I had taught that he like threw cadavers like in successive heights and like saw the velocity. But I looked in further and it seems like, yeah, he like just beat faces with like a wooden club and shaft, and he actually like shot him with cannonballs, and this is how he come up with it.
Dude, old-timey doctors really had the best job.
Yeah, they just messed around.
And then just one quick pearl I want to share with the junior learners here that has served me fruitfully on the ITE. When I was a paramedic student, we had to learn about Lefort fractures, and I'll never forget my teacher at that time. So Lefort 1, Lefort 2, and then Lefort 3, just so you can like easily remember. So Lefort 1 should only involve the superior portion of the teeth over here. Lefort 2 will involve like the sinus area over here. And then Lefort 3 being the biggest one is complete like craniofacial dissociation. So just like an easy like memory trick for the test when you're looking at it if you forget the progression of Lefort fractures.
Yeah, sorry, I can tell I'm running like far behind. Sorry, that's half this stuff is only halfway through, but whenever you tell me to stop, tell me to stop. All right, which are the true avulsed teeth? Anybody? This one is B.
Let's see. A is wrong.
Yeah.
It's within 1 hour. B is wrong because you can put them in if it's early enough.
Well, think about that one. Think about B though. Primary?
Oh, primary? Oh, okay, never mind. Yeah, never mind. Primary. So baby teeth. So that's That's not correct. Best known transport medium is milk. I think it's Hank solution, right? Or maybe it is milk.
No, it is. It's you're right. It's but nobody has Hank solution.
Yeah.
Saliva.
So you can actually just put it in the book, the buccal mucosa.
Yeah,
Mm.
that's it. The best thing is to put it in someone's mouth, which is
Or just
weird.
reimplant it.
Yeah, or just put it in right away. But yeah, the Hank solution is actually better. Yeah, but
That's a great, nice joke, Mike. Let's see. Temporarily secured periodontal pack. Is it
No.
just a splint?
I think it's D because you never want to scrub the avulsed tooth.
Yeah.
you don't want to do that. You definitely don't want to do that.
I would say it's between C or D because maybe I'm reading into the question too much, but I don't know who has Hank's.
No, it's B. No,
Yeah, it's B because you don't put baby teeth back ever because they're done, right? They're gonna fall out anyways. So but the idea is if there's an actual secondary teeth, so adult teeth, is if it's fallen out, you got to try to put it back right away, and you should wash it but not scrub it, like rinse it gently if it's dirty. Otherwise, if it's not dirty, you try to put it, and I've done this. But the biggest chance of it being a viable tooth is to be put it back in within like half an hour. But otherwise, if it's like beyond 2 hours, it's essentially like it's not going to work. And just like you talked, it's like, yeah, Hank solution is the best. But the best thing is to actually put it back in the oral cavity because that's what it likes. And then cold milk is the backup to all of that stuff. And that's all the stuff that I'm saying right there. Actually, if you shove it back in there, I've had people come, you put it back in there and it actually works. And then you have to splint it and essentially, do all the things. And this is the whole thing, like primary teeth. So, if they're young, you don't do it. We just talked about that. And then who knows the classification fractured teeth?
It's Ellis.
That's right.
And it's just like whatever layer is affected.
That's right.
So like, yeah, enamel and then
dentin.
Yeah, dentin is the dentin and then pulp.
Perfect. Yep. And then, we're taught this in emergency medicine, and I have to say, I don't know, Manish, you have thoughts on this, but I found that the dentists break this all the time. But we're taught that, if it's an LS2, then you give antibiotics and they got to see dental right away. And then 3, it's like immediate dental. But I have to say the dentists seem less concerned about this stuff than we are. But then this is how you can tell. So you can see the ring that, that this is the enamel, this is the dentin. And then if you see any pink, that's pulp. So you have an LS3. What are we looking at here?
Parotid stone poking out.
Perfect. What are you gonna do?
Give them
tell them to have some Sour Patch Kids or something.
Yeah, perfect. Yeah. What if they're really sick?
Sialagogue.
Yeah, sialagogue.
Warheads are great. Yeah.
Yeah. What if they look really sick and they're like febrile and all that stuff?
You just keep putting things in their mouth until it gets better. If they look really bad.
Yeah. You'll
It's
be
like the family member trying to feed their obtunded family.
No, exactly right. Yeah. So you try to get them to express the stone. If they get backed up and they have like pus, then you give them antibiotics. You might do some imaging and then talk to your ENT colleagues. All right. This is someone, they're sore throat, they can't swallow, they're febrile, they look bad, and then you see this thing on a lateral neck. What are we looking at?
There's a bullet in the lip. He's been shot. No, sorry. Probably retropharyngeal. Because there's a little bit of like thickening. Oh no, what am I thinking? Dude, I'm like
Come on.
Holy, I should log off.
Yeah,
I
go.
don't deserve to be on this call. The thumbprint sign or whatever. Thumb sign.
Okay, so what is it?
Epiglottitis.
Perfect. Okay. Yeah.
Yeah. Oh my
All right,
god.
so you can see, can you see my pointer?
Yeah.
Okay, yeah. So you see this big sign right here, that thumb. There's a thumb there, and then there's, you know, the normal epiglottis right here on this side. Yeah, and so you know, it's usually like, I mean, H flu is a common one. I have to say, I saw this with COVID. So what are you going to do if you find a patient like that?
To OR for airway management.
That's right. So the OR for intubation, like we're not doing this in the ED. That's what, you know, the test that they should go up there in a controlled setting with their neck prepped for, you know, like an anterior approach for an airway if it, you know, they decompensate. And then antibiotics and all that stuff too, obviously. Okay. So this person, they're middle-aged, they got, you know, their neck hurts, you know, they came in, they had a sore throat, they can't really move their neck. They don't feel that good, and whatever, you get this imaging. What are we looking at here?
Looks like there may be an infection in the subglottic space.
The subglottic space.
Or submandibular, sorry.
Submandibular space, okay.
This is the one I was talking about earlier.
Concerning for, oh no, maybe I'm not. Hold on.
It looks a little thick. Prevertebral.
Prevertebral, right here?
Yes.
Okay, yeah. All right, very good. Yep. So this is the one, yeah, the retropharyngeal abscess. And so there was this, I mean, now we have better imaging for all this stuff, but it used to be that, you know, that this higher level, like C2 and C3, should be less than 7 millimeters. So it should be pretty thin. And then, you know, lower down here, you get a little bit more room for 21 millimeters, but this is pretty thick and you can see that. And I have to say, the cases that I've seen this, and I don't know why, but I've seen quite a bit, is you just see people that are pretty uncomfortable, and then you can't see a whole lot on the throat, and they really don't want to move their neck, and they're really uncomfortable, and you really can't understand why they feel so sick. Kids, I've seen kids with stuff like this, and they get tapped for meningitis and stuff because they don't want to move their neck.
Mm.
And then they ultimately
one of the classic stems for kids is that they had a lollipop or something in their mouth and ran, and then it jammed and popped through the back of their throat, and then that's how they get the infection.
Yeah, I've seen a couple kids in Colombia with that.
Literally just had a kid with that last week at Cornell, went to the OR, even, believe it or not.
Yeah. And then quickly to go through pharyngitis. I mean, I don't belabor this. I mean, they still want us to know this is the Centaur criteria. And so, you know, the exudates, the, you know, cervical adenopathy, the fever, absence of cough. I don't really see anybody really follow this, but this is the teaching is that, you know, 2 or less, you don't have to do any of this stuff and test. And then it's 3 or greater, you test and you treat. What's this?
Uvular deviation.
Okay, so what are we dealing with?
Amy says PTA.
Okay, perfect. Okay, what are you gonna do with it?
Amy, what are we gonna do with it?
I'm gonna go with drain it.
That's good. What are you not gonna hit?
What am I not gonna hit?
Yeah, what are you not gonna hit when you
behind
drain
it?
His tonsils? Wait, what?
it?
Let's say you shoved a needle in there and something started squirting.
It's in a sensitive space. And so we're gonna be a little bit careful of something else.
Oh,
Yeah.
it's like his carotid, huh? Okay.
Yeah,
I like
yeah.
Ed's comment. He says ABG.
Edamora said ABG.
Yeah, you could get an ABG while you're doing that. Like, kill two birds with one stone.
And then you can call ICU triage.
Dude, most
for the abnormally ABG.
Yeah, so you pop it. So most people would like, like either cut a the cover of an 18 gauge and stick it and try to aspirate or make a small incision, but you got to be very careful of like big red right behind that, because it's a tight space. But yes, treating that for peritonsil abscess, the treatment is drainage. This is obscure, but sometimes these stuff comes up because it's like population health and stuff like that. But what are we looking?
Diphtheria.
Unvaccinated, foreign. What are we looking at?
Diphtheria.
Yes, very good. What is that?
Pseudomembrane or whatever it's called over the tonsil.
That's exactly right. Okay, so what are you going to give them?
I don't remember. I'd have to look it up.
Antitoxin. Yeah.
Is it?
Yep. You give them antitoxin, and what are you trying to prevent?
Oh, hemorrhagic pneumonitis.
They get a lot of stuff, but it's
I don't know. I'm just pulling words out of my ass.
Sound pretty good. They can get
heart stuff.
Yes, they get cardio, renal, and like neurotoxicity. But I think the biggest thing, honestly, they test for is if you find somebody for this, like they'll often ask for, okay, so this person has diphtheria, like what are you gonna do with everybody else?
Send them to some island to be quarantined.
For the close context, like what are you gonna do with them?
Don't they get prophylactically antibioticed, or am I?
Rifampin.
Yeah, exactly. They get prophylactic antibiotics to the transmission. Yeah. So they get, like penicillin or like erythromycin to prevent like like grandma and other people that have been exposed so that they don't get the illness.
Dr. Bodnar, just real quick. So we have hit the 10:30 time mark. If folks want to leave, that's fine. And Dr. Bodnar, I'll leave it up to you. If you have quite a lot of slides left, I'm fine calling it a night. But if you would like to finish out your slide deck here, I'm also fine hanging on and
I'm happy to go through, but I mean, if people want to be done too, that's fine with me too. But
I'm good. I'm not doing anything.
Well, I guess there is, but I'll be quick.
Let's do speed round.
Okay, we'll do it.
Speed rapid fire.
All right. Well, I gotta read. Okay, yeah. So here we go. PenG apparently is what you immunize people with, is what the thing. So here we go. I'll be faster if people want to stay. So, okay, 2-year-old comes in, breathing, it's loud. He's got a high pitched cough.
Loud inspiratory noises, mild stridor, frequent bouts of coughing.
He's got a lot of stuff.
Dex.
Yeah. What is it? What's he got?
Croup
is what he's got. Okay. Yep. So we give him dexamethasone. Evidence doesn't say that race epi works, but I mean, I have to say anecdotally it works. And so, yeah. So it's, paraflu is the big one that causes it, and then you monitor them, and then you see if they need more supportive care and see if they get admitted. My eyelid hurts.
Sty
versus blood.
Yeah. Or is it a hordeolum?
Well, we'll see. Is it
this Calazion?
This
or pterygium? It's not a pterygium.
No,
I'm going to say hordeolum.
Yeah. So the hordeola can be like an infection of either of these things. So it can be this, this internal one, or it can be these, external glands. It's basically an infection of these glands. We call it that when it's acute, and then there's like a little superficial infection, or it's just inflamed. Of that, it's just like a broad term for all of that. The thought is, at least when you look at the literature, is that the sty or the hordeolum is like an acute thing, inflammatory or bacterial, and the chalazion is the chronic thing that's like doesn't hurt as much, and it's just like a bump there. That's the distinction. What's this?
Conjunctivitis.
My eyelids are just irritated. No, my eye feels fine. Just my eyelids are irritated.
Oh, blepharitis.
That's right. So it's just the like the
Just
little
look really
glands.
greasy.
Yeah, she looks a little greasy. She does. It's just the fact that the eyelids, the end of it, like those glands get obstructed. Usually I would say is what this is secondary to is something someone's putting on their eyes. So like medication, they either have like a reaction to that, or they're clogging up the stuff with like eyeliner or other things that they're putting on their eyes. And so it's usually discontinuing the stuff that causes that. All right, baby comes in, their eye is really pussy, 3 days of life. What is it?
Gonorrhea.
That's right. Why is it?
Because gonorrhea goes first.
That's right. So very first often and really powerful. Like gonorrhea conjunctivitis is impressive. It is impressive. It is nuts. If anybody's seen this, it's insane.
It's awful. People just keep pouring stuff out of their eye. It's awful.
Yeah, it's really insane. You won't forget it. And then so the later you'll see that the chlamydia, but the idea is that gonorrhea, like obviously they need to be treated aggressively. And then the chlamydia, the one thing that you need to know about is that if they have that later, is not only is it there, it's not as impressive, but they need they don't need topical, but they need systemic antibiotics too as well. Then later on we know it's mostly viral, and then other irritation is like antihistamines, etc. Okay, visual diagnosis. What are these three things?
Endophthalmitis.
Oh shoot, I hope not.
I don't know. It's cloudy and nasty looking.
No, but you've got look, think about it. You've got a
Corneal ulcer.
woods lamp. You got a woods lamp on there, right? So what?
Oh, is this the same? Is this all the same eye?
No, it's not the same eye. They're different. They're all different diagnoses. So this is something, this is something, this is something.
Well, the top right one looks like the dendritic ulcers.
Correct. I agree.
Perfect.
HSV.
Okay. What's this one?
I don't know what that is. Is that just a cataract?
Cataract.
Is that one of those eye worms?
The
Filaritis.
massive corneal abrasion in the visual axis.
This is
it Wilson's disease?
This is an abrasion.
Bodnar, if you say that's a normal eye, I'm going to come to your house right now.
That's a few nights ago when I snuck over to Mike's apartment and peeled his eye open.
No, this is one, it's not, I mean, to be fair to you guys, it's not as good of an image. It's hard to find, but this is a corneal ulcer. It's like the uptake around this is on me. But it's like the uptake around the edges of it. And I have to say, I don't have it that much. I'm just showing it without the fluorescein, but that's what it would have. It's like the uptake around the edges, but seeing it like without it is, I think is interesting. But the important thing about it is if you find a corneal ulcer, is to like, that is one of the things that we need Optho to see. That's one of the things that you say, wake them up to be like, we got to talk about this. You got to have a plan for how you're going to treat this. So yeah, so you get Optho involved immediately. Topical antibiotics. Sometimes they do steroids, but that's on them. And then to be very wary with the contact lens wearers. Everybody that I've seen with this, and I'm sure Venetia is the same, as the sorry, some through just like it's like people that have something that they put on their eyes all the time. And then you called it out, the dendritic pattern for the herpes. Dendritic pattern through all that stuff. And then we give the, oral or topical antivirals, and then not as fast, but you talk to Optho and then you can have them see them later. That's the same thing. They often give steroids. That's per them. We don't do that. And then the corneal abrasion, which we see all the time, that you can see, it's just like that. And it doesn't have the uptake just around the edges. It's got like a clear pattern over the entire thing. And then it's just mostly supportive care, but you really want Optho to follow them, especially if it's over the center area, because they need to follow it for, it's a scar on the skin, and the cornea is essentially kind of a skin, and it can be vision changing. So they definitely need to follow up with ophthalmology. Okay, this guy has facial pain and fever. What are we looking at?
Orbital cellulitis.
How do you know it's not preseptal cellulitis?
Looks like it's heavily involving the lid. He has systemic symptoms.
Okay, that's good. What else would make it orbital cellulitis?
Pain with eye movements.
Perfect. What else?
Neuro symptoms. Like cranial nerve stuff.
Yeah. So it's good. So like pain with eye movements, swelling around the eye, like if it was proptotic, if you had vision changes. Those are like the major things. Kids, it's very challenging, I have to say. I don't know. Most people, I guess, I've seen some, it's really challenging. When I first started, I would work in the PZD, and you'd see something like this, and it's really hard to try to get the kids. I mean, you can't obviously do like painful extraocular movements, and those things are tell that we have double vision, and so when they just have a swollen eye, it's really like a judgment call to try to think about it. But any concern, obviously, you have to do 3D imaging to see if it's in front or behind. And then, but either way, that they're getting antibiotics. And then what's the major reason why you have to get it if it's orbital cellulitis?
So typically the orbit's an enclosed environment. So if you have an infection invading the orbit, given the venous system and the lack of valves, higher risk for meningitis, venous sinus thrombosis, all those sorts of things.
Exactly. So that can be further spread. And then it's also a compartment, right? So it's a compartment, and then it can cause that typical compartment syndrome. So absolutely right. This poor lady, she got a headache now. She's got some blurry vision. She went to go see a movie, and this happened to her. I don't know what happened to her.
Angle closure glaucoma.
Perfect. All right. Great. What does she see on her eye that describes that?
Non-reactive pupil, which what appears to be a pretty bright light.
Yep. And then what else is like? What else looks at the eye? It looks kind of
maybe. I don't know if
like limbic. It's like, right? Is that a thing? Limbic sparing, or is it like for trauma? Can't remember.
That's for iritis, but yeah, it's the cloudy cornea, right? That's what you're trying to.
cloudy. Yeah, it's like a cloudy.
Yeah.
This is like what that cornea typically looks like. It's a little cloudy. But you guys are very good. It's good. And so yeah, and so the whole idea is that the eye dilates, and then it closes off this the outflow, and then you get stuck there, and then you get those like high pressures. So what are we going to do to treat it?
Eye drops.
Well, just like the stuff the Visine, you're giving this patient Visine.
Yeah. You can do the beta block carriers because they decrease humor production. You can do like acetazolamide, and then
You made this slide, it seems like.
I don't know. Do we do cycloplegics to try and like prevent it from dilating? Is that a
That's
thing?
right.
Oh
That's
yeah,
exactly right.
pilocarpine, right?
Yep. And that's what they will tell you to do if you had has anybody had a case like this?
Yeah, I feel like it's always acute on chronic, so they're not really in a rush.
Yeah, maybe that's something pretty aggressive. They'll tell you to do this stuff, and so yeah, and then they do that, and then ultimately, then they they need to do an iridotomy, and where they put a little hole in there so that to prevent it in the future, like acutely. So, but yeah, but that's what we do. Okay, 58-year-old comes in with flashers, floaters, and left eye, and no other changes to her vision.
Painless. It's probably vitreous hemorrhage. Let's see. Visual field deficit. Oh, okay. In the upper temporal visual quadrant of her eye. It's probably not infectious, so it's not posterior uveitis.
Retinal detachment, flashes and floaters would be my guess, or partial retinal detachment.
Let's see.
Vitreous detachment. Oh, dang it.
The-
Right.
Yeah, I mean that's probably what I'd guess. It's just weird that there's a quadrant visual deficit.
Throwing me off. I'm between B and D. Uveitis should be painful to my understanding. Diabetic proliferative retinopathy shouldn't be acute. Vitreous hemorrhage, there's no real trauma. For the, I don't know. I want to say B just because I don't think it's a full retinal detachment.
I'm gonna say A for the flashes and floaters.
It could be all of those, honestly. For us in the ED, it's very difficult. It could be B, D, or A, but the most worrisome thing is the D, and that's what we have to get ophthalmology involved with so that they can look at the retina. And that's what you'll find. I mean, I've found this, like I've seen this case like 1,000 times, not 1,000, but I guess tens of times. And then it usually is something like it's a vitreous detachment or a hemorrhage, but then like in the few cases that it's a retinal detachment, like it needs to be intervened on for the most part, especially if it's getting close to the macula, they need to tack down. And so that's what we have to be wary on, and we don't know, like based on looking at all these things. And so I'm glad you guys went through all that stuff, because for sure it could be any of those, but someone needs to look at the retina to make sure it's not one of those. And so, I mean, for this case, they said it's the retina, but it could be one of those things, any of those things that you just said. All right, visual diagnosis. What are we looking at? There are two different things, left and right.
CRVO and then CRAO.
Yeah, very good. So which one is which?
The left is the V because it's very red and angry looking, and it's just some bleeding. And then the right, it's like very pale, and you get the macula, the cherry red spot.
Exactly right. So what are you going to do?
You're gonna rub on the eye on the right one.
Okay.
Maybe give TPA, call neuro, and then on the left, you can't really do anything, I think.
Yeah, it's questionable whether you do anticoagulation, and now there's like this thought of doing intravitreal like injections of anti-VEGF, because they think that this like blood cell proliferation like will combat edema. But yeah, not much for us to do, unfortunately. Yeah, agreed. So very good. So one is the the blockage of the venous system, and so the backup, and so on the left the veins get super engorged and puffy and angry, and the other side is there's no arterial blood flow, and so it's super pale. So well described. Nice work. Okay, this guy's got some eye pain at work. He's a craftsman. This guy's a metal worker. Comes in, you do some testing, you see this. What are we looking at?
Teardrop pupil globe rupture.
That's not the pupil, but that would be a good.
Oh, really?
That's not the pupil. I'll give you a hint. You've stained this eye.
Oh, Seidel sign.
That's right.
Oh,
I saw this though, like the pupil though, like the iris gets sucked out of the hole, and it looks all messed up.
The
Is that what you were
iris-
saying, Mike?
yeah.
The iris the iris gets sucked out of the hole.
It's a weird way to describe it, but like you can see the coral or the ciliary body kind of like get pulled out of the hole because I think the pressure from inside the eye kind of forces it out, so it like deforms the pupil.
The pupil gets deformed in some of those cases. I mean, you're both obviously right, but the Seidel sign is essentially what you are doing is that you stain the eye, and then unfortunately the humor is like draining out and pushing away the fluorescein, and so you can see that like flow of water that's pushing it away, so that you know that there's a hole there. So what are you going to do with it?
Put eye patch on it.
Yeah, you don't want to touch it, right? What else?
Make sure you check the pressure every 2 minutes. Topical antibiotics.
And not topical antibiotics, nothing. You
Hmm.
don't touch it, obviously.
Yeah. I mean, besides calling off though.
Call up though, for sure. You give IV antibiotics.
Mm.
Never forget the update tetanus, which I know sounds silly all the time, but that's what you do. And then, yeah, this is like definitely an emergency. Yeah, so all this stuff, IV antibiotics, emergent Optho. You don't do anything in the eye anymore. Sometimes people just put a whole like cone or a patch on the eye so you don't mess with it. This whole thing about intubating is debatable, but that was in their old literature.
Let me look through this. I went on a huge rant and I wrote like a 20-page essay on rock versus sucks because I kept getting into arguments with Caroline, the pharmacist. But I've read a lot about this. Let me look at it while we're going ahead.
Yeah,
Sorry.
I
like read like 5 studies on this because I
don't feel
so
strongly one way or the other. I think it's all, I think that it doesn't really matter whether you're intubating what you're doing, but yeah, it's fair one way or the other. I don't have any opinions on it. But sometimes that stuff can come up in old literature where people are talking about it. But what are we dealing with here? We're almost done. Couple more slides. We're almost done.
Lymphoma,
Okay.
respiratory glaucoma, and obstruction of the trabeculae.
What are we going to do? Well, you can get that, but what are you going to do with it?
You know, rub their tummy and make them feel better. I don't know. Can't do anything, right? Oh, okay.
You can do that if you want.
I didn't say anything either, but I'm still laughing at you.
Yeah, this is the thought, is to help with like supportive care, and then if they have something that that they're on that they need to be reversed, like you got to be careful of that to prevent the the further bleeding, and then the pressure, which is the whole thing with the head of the bed being elevated. And but the big thing is to keep an eye on is what you just talked about, is that they can then develop the acute glaucoma if they're sickler, because those cells can get stuck, and then they can get in bad shape, and then they can get, so that's one thing. If you have a sickle patient with that, you got to be very worried.
No acetazolamide for them.
Yeah.
Okay, aside, I went back and looked at my paper, but there were four studies that looked at this that basically confirmed that IOP increases exist with sucks compared to rock. Even and they like confirmed it in patients who were like undergoing like elective enucleation for other things. So they just like fucked with the eye and measured all the pressures. See how to avoid it. But I don't think
don't give sucks.
correct.
Okay. All right. I'm down with that.
But those are all like 20 years old. Nothing's been done since.
Well, whatever. I almost never give sucks anyways anymore, but that's even more ammunition. I'll say that Matt says don't give sucks. So I'll say don't give it. What are we looking at? Oh shit.
I was going to say cells and flare, uveitis.
All right. Yeah, perfect. I would encourage people to play around with the slit lamp. I know it's a pain to set it up and to get somebody there, but you can actually see this. I have seen this. I've done this and I've seen it, and it's kind of fun to do these exam and you can see this stuff. And so that's just my little, diatribe to say that. But okay, cells and flares. So what are we looking at?
Mike, what are we looking at?
So, to my understanding, so the thing all the way on the right, that's the light beam.
No, you don't have to say what it is. Like, what's the diagnosis? Like,
oh, the diagnosis is uveitis. Uveitis.
Yeah. So it's
Sorry,
you may have already said that. Sorry, you might have already said it. Yeah. So it's uveitis. So these are inflammatory cells that are in the anterior chamber that are irritated. So it can be a lot of things can cause it. We often see it after someone's had some trauma and it's inflamed. And so they'll have an irritated eye, and then you can see it after it's been hit. And so they'll have an irritated eye, and you can see cells and flare. But sometimes you'll see this instead of the hyphema, it's the hypompion, which is like the white blood cells that are below it, which is rare, but you may see that with it. But the one thing outside of seeing in the exam findings is if you have someone with eye pain, they got hit in the eye with something, they're somehow irritated. If you shine the light in the unaffected eye and the eye that's of question hurts, that's usually that it's because it's iritis or uveitis. That's one of the hallmark signs. That I'll just put that out there. But that's it. That's and this is supportive care. I mean, you could further into ophthalmology into